Dear colleagues, welcome to our webinar. This evening, we have very distinguished speakers from all over the world. I would like to thank to them for accepting our invitation. This webinar organized collaboration with IASCO, ONCAT, and Marmara University as a part of postgraduate course of IASCO, and will continue with different topics as a series. I hope and I am sure that this webinar will be very fruitful for all of us. You can write your questions and we will translate to them to the speakers at the end of the webinar. Now I would like to give a word to Professor Faysal Dane and then Professor Duda will give an opening speech. Professor Faysal Dane, please.
Thank you, Ender. Dear valuable participants, I wish you all and your family a healthy life during this COVID pandemic. As Professor Ender said, this webinar is organized in cooperation with ONCAT and IASCO. As you may know, ONCAT is a medical oncology association in Turkey. And today we are going to talk about pancreatic cancer. And now I would like to invite Professor Duda for giving his opening speech, especially related to IASCO. Please, Professor Duda.
Hello, everybody. On behalf of ISGO, it is my distinct pleasure to welcome everybody to this webinar. These are new times, much more difficult for us, but the mission remains the same as it's been for the last 3 decades, globalization of the best medical knowledge. And I want to congratulate Professors Dulundu and Dane for putting together such an interesting program on a topic that remains an unmet need in all the disciplines of oncology, which is pancreatic cancer. And I think you'll hear today a lot of the latest developments. I'm sure there will be a lot of interesting discussions. Once again, I welcome all of you and look forward to very interesting discussions. Thank you very much.
And now we are going to start our webinar. First topic is first lecture is given by the Professor Elena Usova. She has a great experience about pancreatic surgery. She is participating from Moscow, and she's an honorary member of the IASCO, and she's going to give a talk, Duodenum preserving pancreatic head resection, how to do and when. Yes, Professor Elena.
Dear colleagues, good evening to everyone from the sunny Istanbul. Happy to be here today, and let me share you some small experience on duodenum preserving pancreatic head resection. Okay, let's start. So what stands for duodenum preserving pancreatic head resection, as well as when it can be applicable? So the definition of duodenum preserving resection goes back to late 70s, early 80s. And it could be defined when you mean total duodenum preserving resection as resection that is conserving pancreatic neck. And most of the pancreas consequently, and peripancreatic segment of the duodenum, it might be either common bile duct, it might be either resected or preserved. Unlike total partial pancreatic duodenum preserving pancreatic head resection is intended to preserve the duodenum and common bile duct, as well as some parts of ventral and dorsal pancreas. And also we have subtotal duodenum resection, subtotal duodenum preserving resection that was originally designed by Professor Beger, and it presumes sparing the thin layer of pancreatic tissue on the duodenum. First, Professor Beger started his on dog experiments early 70s, and already late 70s, he demonstrated 12 patients with both chronic pancreatitis and benign pancreatic tumors. And the outcomes for quite young population group were demonstrated to be beneficial, and there was reported no mortality and 75% of complete recovery after surgery, 3 years after surgery. Then we need to mention Imaizumi from Japan. He suggested total duodenum preserving resection, which presumed the removal of the whole pancreatic tissue. And he emphasized on avoiding cauterization of duodenum in order to preserve blood supply to its parts. Then later on, Professor Nakao suggested duodenum preserving resection with resection of a small portion, actually peripancreatic duodenum segment, to avoid duodenal ischemia. Also in 2004, we need to mention minimally invasive procedures. Professor Takaori from Japan, he demonstrated laparoscopic duodenum preserving resection. It was complete resection of, it was total duodenum preserving resection, and for anastomosis, he proceeded to a small incision in order to avoid any complications like pancreatic fistula, since it was the first experience in the world. Also, we need to mention robotic duodenum preserving resection. The biggest and single center largest experience belongs to Chinese authors. They also demonstrated many benefits of this surgery, especially in regard to blood loss, and time of the surgery was also significantly decreased when gaining experience of this procedure. This surgery became quite popular among pancreatic surgeons for chronic pancreatitis. Probably the reason was that when we have chronic pancreatitis in patients, it gives a false sense of safety for surgeons. We are thinking that fibrotic changes can give you less pancreatic fistula risk, but in fact, it is not. Nevertheless, authors demonstrated, authors from China demonstrated several benefits of this procedure for chronic pancreatitis. Also in light of delayed gastric emptying, was significantly decreased. Endocrine insufficiency was significantly decreased, as well as duration of postoperative stay and increased quality of life of these patients for duodenum preserving procedure. The first probably meta-analysis has been done by Professor Beger. He demonstrated 25 papers with 416 patients, and also new-onset diabetes mellitus was significantly lower in duodenum preserving group. Also, you can see how this procedure has been changed, and if first this procedure was applied for chronic pancreatitis only, then it slowly became popular among surgeons for benign tumors and low-grade tumors of low-grade malignant tumors. You can see here it is much more publications, and here authors also demonstrated a separately experience of total and partial duodenum preserving procedures. The severe complication rate was reported for both procedures to be about 13%. Here you can see how this procedure has been designed for low malignant neoplasms. Cumulatively for over 500 patients, and most of them was with total duodenum preserving resection. Although Dr. Berger does not like minimally invasive surgery, here he demonstrated 37 patients with minimally invasive approach, both laparoscopic and robotic. Also, the definition of this procedure may vary among institutions. Sometimes it could be represented as a resection of uncinate process, which belongs to partial duodenum preserving resection. Here also authors demonstrated resection and how it could be called. It remains up to each surgeon. But as far as some researchers demonstrated that over 50% resection of pancreatic head parenchyma belongs to subtotal resection, while less than 50% parenchyma volume could be defined as partial. And primarily why 50%? Because over 50% sparing of the pancreatic head tissue allows us to preserve exocrine function of the pancreas. The key point in this procedure is sparing the blood supply to duodenum. This problem was first, its roots goes back to the middle of 18th century. And in Haller's manuscripts, we can find already some arcades between, he demonstrated existing between anterior and posterior arcs of pancreatico-duodenal arteries. The anastomosis which are known to be between celiac axis and superior mesenteric artery. Also, not many studies demonstrated the microscopic specimens and presence of those anastomosis. Falconer demonstrated study on 50 specimens and preparations, and he demonstrated the presence of anastomosis behind uncinate process from anterior pancreatico-duodenal arteries. And sorry for misspelling here, the last one is posterior superior PDAs and posterior inferior PDAs. And both those are anastomosis between celiac axis and superior mesenteric artery. And those both are located on the posterior aspect of the pancreas. So that's why this is extremely important to do surgeon's best to preserve the posterior surface of pancreas and dissect that area as less as possible. Also, there was a series of studies demonstrated the importance of artery of Haller, which most commonly arises from splenic artery, and also it could be originating. It could originate from common hepatic artery and others. And this artery, it goes behind superior mesenteric vein, and its course is important to preserve because of also it supplies its branches supply the duodenum. So in order to avoid duodenal ischemia in the future and complications during postoperative period, we need to spare this artery. And also here we can find a huge help from our radiologists that can define whether this artery is present and how prominent it is. Also, Japanese authors demonstrated the blood supply, some features depending on embryological aspects of the pancreas. The pancreas has two buds, as we know from embryology, a ventral bud, the smaller one, and dorsal bud. Ventral bud usually goes to and becomes uncinate process, and it is mostly supplied by superior mesenteric artery. While dorsal bud, the bigger one, it represents the rest of the pancreas and is mostly supplied by celiac axis. Also, as we can see, most of the studies goes from Japan on pancreatic head blood supply and duodenal blood supply. Also, Japanese authors demonstrated the arcade formation in most of the cases between posterior pancreatico-duodenal arteries and in 100% cases between anterior pancreatico-duodenal arteries. But how we can remember from former slides today, most of these anastomosis are situated on the posterior aspect of the pancreas. Also, there was found a connective tissue membrane on posterior aspect. So when we are doing the resection, the main goal here maybe not to preserve anterior aspect of the pancreas, but mostly posterior. Also, there are several questions on whether to preserve a gastroduodenal artery and whether to do Cocker's maneuver. As for gastroduodenal artery, studies made by Imaizumi, as we know, they demonstrated that there is no need to do to preserve this artery. Nevertheless, if you cut this artery, you need to avoid cockerization of the duodenum. Otherwise, you might get necrosis of duodenum partly, and also you will not be avoid the postoperative complications. Also, we need to also to focus on long-term outcomes. And as we can see, authors here from Germany demonstrated, it was back in 1995, they demonstrated that duodenum preserving resection is much more beneficial, in light of decreasing of postoperative morbidity, and when they compare these to Whipple procedure, the postoperative morbidity after Whipple was completely higher. Oh, it was significantly higher. But we need also to mention recent study, a multi-center study made in Germany. Here also authors demonstrated that there was no difference in morbidity, mortality, and quality of life for 24 months after surgery. And this study also demonstrated fewer admissions after pancreatic duodenectomy. And the reason was that the reason for admissions was mostly pain, postoperative pain, and postoperative pain was significantly lower after pancreatic duodenectomy while you're removing the substrate of the pain, so pancreatic tissue itself. Also here, Beger demonstrated some parenchyma sparing resection, meaning he demonstrated this in meta-analysis and systematic review. And it was a severe complication rate was significantly lower for total duodenum preserving resection, and for subtotal it was not so much good. Nevertheless, authors recommend this procedure, especially for patients with low-grade malignancies. Let me demonstrate you some case presentations of patients. The first one was young female. She was presented with typical Whipple striate, and she came from abroad and she was experiencing symptoms for almost 2 years. After that, she got pregnant, and interestingly, all the symptoms resolved during pregnancy and early breastfeeding period. And after that, she experienced symptoms resumed, and she experienced hypoglycemic episodes. The lesion has been detected on MRI, and interestingly, she had primarily normal insulin level, and upon admission to our hospital, the insulin level it became slightly increased, but mostly she had proinsulinemia, and C-peptide was also normal upon admission. Nevertheless, we evaluated her for Mann syndrome and for other signs and causes for hypoglycemia, and they have been ruled out. On CT, the lesion was presented as pancreatic HEC lesion with close proximity to main pancreatic duct in about 2 millimeters, and with some arterial features. Here is the testing has been done in order to rule out any other lesions, any lesions like this, like insulinomas in other regions of the pancreas, and the lesion in the head has been demonstrated as being the only one. We performed partial duodenum preserving resection since the lesion, as you can see on ultrasound here, it was presented as an intraparenchymal, and small portion of pancreatic head parenchyma was also needed to be removed. The lesion was demonstrated as on hematoxylin eosin stain. It was presented as typical insulin secreting tumor, and staining with markers, with insulinoma markers, was positive. Also, I would like to demonstrate another case presentation of a 55-year-old male. He presented with symptomatic pancreatic head lesion, and he also underwent meticulous preoperative workup. And during that workup, it was impossible to detect the exact nature of the lesion. Just we also were uncertain whether this lesion could be a neuroendocrine tumor or maybe other ones. Here you can see about 10 centimeter pancreatic head mass, which was symptomatic because of some duodenum compression symptoms. Also on MRI, it was detected as multicystic lesion. We proceeded with laparoscopic duodenum preserving pancreatic head resection. Mostly this lesion was extrapancreatic. So nonetheless, this we have been given the false sense of safety, because when you have an intrapancreatic lesion, you might pay much more attention to pancreatic parenchyma and how to manage it. Here, maybe it would be useful for other surgeons who would like to proceed with those procedures. The extrapancreatic, mostly extrapancreatic location, it is not always safe to proceed with this procedure. So with such kinds of lesions, you need to be careful as well as with intraparenchymal lesions. So as an outcome, we had a Bassi pancreatic fistula and grade B bile leakage. Fortunately, we managed this patient without any additional surgeries, just minimally invasive. And surprisingly, on pathology, it was this lesion was detected as pancreatic hemangioma. So as a conclusion, what the key aspects I would like to summarize and emphasize for this talk. So the most important, probably the key to success for this procedure is the sparing of blood supply to duodenum. As for mesoduodenum, you might know also mostly can be approached from the posterior aspect of the pancreas, so that's why the dissection of the posterior surface of the pancreas is not recommended here routinely. And for partial duodenum preserving resection, this is probably the only resection among those three ones, total, subtotal, and subtotal, which could be used, where cauterization of duodenum could be used if necessary. Now, for other procedures, we think cauterization is not necessary. Moreover, we have conventional endoscopic ultrasound, conventional intraoperative ultrasound, I mean endoscopic laparoscopic ultrasound. If you proceed with laparoscopic duodenum preserving resection, that could help us to avoid additional dissection of duodenum and pancreas. And as for now, we do not have any study comparing duodenum preserving resection with conventional Whipple procedure for focal pancreatic lesions, unlike the studies have been done for chronic pancreatitis. Because chronic pancreatitis, we can already say benefits or maybe disadvantages we have for focal lesions, where the most of the parenchyma, pancreatic parenchyma is not changed by, does not have fibrotic changes. We need to do those studies, and hopefully those studies will appear in the future, and hopefully multi-center studies. Okay. And thank you for your attention.
Thank you. Thank you, Elena, for your excellent lecture. And I would like to move to the Professor Hackert. He's a well-known pancreatic surgeon. He is the vice chairman of the Department of General Visceral and Transplantation Surgery at the University Hospital in Heidelberg. And he became head of the section for pancreatic surgery in 2014 and head of the European Pancreas Center of the University Hospital of Heidelberg. And special focus has recently been laid on robotic pancreatic surgery, which has been introduced in Heidelberg in 2016 and is increasingly performed for all types of pancreatic resection. And he has worked in committees for national guidelines for chronic pancreatitis, pancreatic cancer, as well as the European guidelines for cystic tumors, and is council member of clinical science in the European Pancreatic Club. Thank you very much, Professor Hackert, for accepting our invitation. And we are going to listen to you about the surgery for borderline pancreatic cancer. Thank you very much.
Thank you very much for this kind introduction and the invitation to participate, although we can only do this online at the moment. I will try to start my screen sharing so that we can, yes, start right away. Okay, is that fine? Screen sharing is working.
Yes, fine, fine.
Okay, perfect. Now, I want to talk about surgery for borderline resectable pancreatic cancer today. And of course, this is a topic of debate at the moment. We all know that surgery is important, but we need adjuvant therapy, of course, chemotherapy, and we need neoadjuvant therapy in some cases of the patients. And I will go to that because borderline resectable and locally advanced, you cannot discuss without mentioning neoadjuvant therapy. Borderline is basically, from our point of view, when you have a venous involvement of the pancreatic cancer, of course, a limited arterial involvement as well. And the locally advanced is, of course, the more extended arterial involvement. This I will come to a little part of my talk. Now, what is resectability in pancreatic cancer? Probably this is the most commonly used definition from the NCCN adopted by the International Study Group of Pancreatic Surgery. And you see, this is only anatomy. This is only about the veins, about the arteries, what is borderline, what is unresectable, and of course, only technical considerations are included in this classification of resectability. I think that there is more, and therefore the IAP in 2017 came up with this definition of borderline resectability or unresectability, because it's not only about anatomy. Of course, also in this IAP classification, anatomy is the most important backbone. You see, it's more or less adopted from the classification I just showed you. The venous involvement, the arterial involvement is all mentioned here as in the ISGPS or NCCN classification. But the important thing is that also anatomy has its limitations. When you come below the duodenum, the lower portion of the duodenum, the vessels are becoming small, and this will turn to an unresectable tumor by any time, even if it's only a venous involvement, because it's just too small and you have a high risk of a thrombosis afterwards when you do this. More important from this definition, I think, is the tumor biology as well, because this means that the tumor has an unfavorable biology, which is shown by a high CA19-9 or proven lymph node metastasis, either by biopsy or by PET-CT. Because when you have either of this, either the CA19-9, which is very high, prognosis becomes much worse, or when you have the positive lymph nodes, you see these curves here, prognosis becomes much worse in all stages except for T4 tumors. Then it doesn't matter what the lymph nodes say. The third part of this classification is the condition of the patient. This is the part C, which means patients with a poor performance status will probably not benefit from an upfront surgery because they don't recover very well. They will maybe not get their adjuvant therapy, and therefore their prognosis is also significantly worse than the patients who have a good condition and who are fit for surgery. And therefore the IAP has just recommended to use this classification of resectability, which means even an anatomical resectable tumor might become borderline by the tumor biology or by the condition of the patient. And therefore this might guide your decision-making for upfront surgery or not. Now, what about the borderline situation from the surgical part of view? You have venous resections, you might have arterial resections. This is an example. You see these arterial infiltration on the left side, and in the same patient, the venous infiltration on the right side. And of course, you can resect this, you can replace the celiac axis, you can replace the portal vein. This is technically all possible. But the question, of course, is should we do this or should we don't do this upfront? Just to underline a little bit of the debate, this is a most recent publication from the French study group. They did their recommendations how to handle these venous involvements, and they did a literature search on all of the studies that are available at the moment. Everything was included, and the recommendation is quite clear. In France, venous resection is technically recommended, yes, but whenever you plan to do this, you should have neoadjuvant therapy for the patient. This is also clear recommendation from this work from the French colleagues. Why is the technical consideration important? You have a morbidity when you do these venous resections. However, when the patient has gone out of hospital, long-time patency of a venous reconstruction is quite good, 76 to 94%. Acute thrombosis, however, is a problem. When you have an acute thrombosis after venous reconstruction, this is a very dangerous complication, maybe less than 2%, but if it happens, it might look like this. This means whenever you have the suspicion on the evening of your operation or the day after that your venous reconstruction is not patent anymore, you have to act immediately. Otherwise, the patient will leave the hospital without his small bowel, or he will not leave it at all. The problem at the moment is that there is no good data how to do post-operative anticoagulation for the venous and even for the arterial reconstructions in pancreatic cancer surgery. So this is something which is not really well defined. I think every center does it a little bit like they feel. What about the oncological outcomes? Coming back to the French study group, once again, you see from all the literature they analyzed, morbidity is equal, mortality maybe a little increased in hospital, but when you have excluded the post-operative problems, even oncological results are worse than for the non-borderline patients. So you see the 3 and the 5 year survivals are significantly worse. And of course, this is the reason why the French say everybody needs neoadjuvant chemotherapy. Now, what should we do in the neoadjuvant setting? We know in the adjuvant setting that we have good data for FOLFIRINOX, for GemCap, and for nab-paclitaxel and gemcitabine. To underline this, FOLFIRINOX, of course, is very good adjuvant. GemCap is very good adjuvant. NAP, gemcitabine, is disappointing in the adjuvant setting, so probably this should not be your choice for a neoadjuvant regimen. We have no data from any adjuvant study for radiotherapy or sequential chemoradiation. So, of course, this is done in the neoadjuvant setting, but it is based on limited data at the moment. And I don't want to go into all of these studies for neoadjuvant therapy. I just want to mention one study that was performed from Liverpool and Heidelberg and many other centers in the UK. This was the SPAC5 study, just presented at the ASCO this year as an abstract, not completely published. But you see, this was just a feasibility study, borderline resectable cancer, upfront surgery, GemCap, FOLFIRINOX, or chemoradiotherapy in a randomized setting, only 100 patients, just feasibility. The primary endpoint was recruitment rate. Is it possible to get these patients to neoadjuvant chemotherapy? Because at the moment, this is not very much favored in Germany, at least. And what is the resection rate? Even in this study, resectability was only defined on anatomical issues. All were borderline, but only from the CT scans and from the anatomy. No other features were included. What you see is the results after completing nearly some of them. The R status was as you see here, a little better in the chemoradiation group, FOLFIRINOX and so on. And this is just one of the parts that came out. The primary outcome, of course, was the recruitment rate. And you see, we did not manage to meet the 100 planned patients because it just took too long. Patients in Germany say, if I can be operated, please operate me. I don't want to have neoadjuvant because we just don't have the good studies at the moment to convince them. What is the further outcomes? Resection rate, immediate surgery, neoadjuvant treatment, absolutely the same. It was no difference. R0 resections as a secondary outcome, also exactly the same, no difference in here. Now the secondary outcome is the overall survival. And of course, this is something that is quite interesting because the neoadjuvant treatment resulted in a better survival after 12 months. And when you look at the lower part of the slide, you see that FOLFIRINOX did best. That was the best survival rate when you had neoadjuvant FOLFIRINOX. We were quite enthusiastic about this. However, we have to keep in mind this study was not powered for survival. This study was just powered for feasibility and recruitment. So of course, we have to go into a large randomized trial now with these data and probably choose FOLFIRINOX versus upfront resection in borderline resectable pancreatic cancer to create better data with the outcome of overall survival as the primary endpoint. Now coming to the second part, borderline arteries. You see this is an example where the celiac axis is actually more than borderline, it's more locally advanced, invaded. And you can, of course, resect this, reconstruct this with an allograft or with anything else that you have on the celiac axis on the aorta. And the SMA you can clean. And this is a nice operation. Technically, everything fine. What is the outcome? Old meta-analysis from 2017 on SMA resection and pancreatectomy, very rare operation, only 70 patients in the literature by that time. And to make it short, this is a picture how you can do this end-to-end anastomosis of the SMA here, but survival in median 11 months. This is the same as FOLFIRINOX. You can spare the operation, you can just give FOLFIRINOX. This is historic data on arterial resections from my point of view. Now I want to show you two new studies on arterial resections. First of all, the Mayo Clinic, pancreatectomy with arterial resection, published 2 years ago. Also historic, but also more current data over a nearly 30-year period, 111 patients that they operated. There's an example from this publication with a nice double graft on the hepatic artery and the SMA, and of course a patch on the portal vein you can also see. The interesting thing about this study is that you have to do this often to be good at this. When they analyzed the patients done before 2010, you see in the lowest line of this table a mortality of 29%. This is certainly nothing you want to offer to your patients. After 2010, when you have increased your caseload, mortality is only 1/3. And I think when you increase even further, this can be even lower. So, however, when you do this often, you might do this well, and this is a feasible option. In this paper, also, neoadjuvant therapy was important for these locally advanced pancreatic cancers. Survival of this cohort much better with neoadjuvant therapy than surgery first, but of course, this is only an observational study. The impact of neoadjuvant in locally advanced, however, is unquestionable, I think. I want to show you some data from our center. These were nearly 600 patients treated for locally advanced pancreatic cancer neoadjuvant setting, 125 for FOLFIRINOX, 322 gemcitabine radiation, which was before other therapies, 128. And our experience is when you have a neoadjuvant treatment and you have a stable disease, you cannot predict anything from the CT staging. You have to go to the OR and have to check if you can resect it or not. This is an example from this study, large tumor staging after FOLFIRINOX, you would say probably not resectable. Go to the OR, take frozen sections. If it's only scar tissue, you can go along the arteries and take this tumor away. We have called this operation triangle because you clear the SMA, you clear the celiac axis, and you clear the portal vein, and you don't have to resect the arteries in many of the patients. In FOLFIRINOX patients, we could do this most often in 60% of all of these patients, and this was the best series compared to the other neoadjuvant therapies that we had. So we think that at the moment, FOLFIRINOX is the best you can do. when you have done the operation, survival is absolutely equal, no matter which neoadjuvant therapy they had. You just have to achieve the resection itself. And of course, you can achieve it in more patients with FOLFIRINOX than with other chemotherapies or chemoradiotherapies at the moment. And then the survival of all of these resected patients was significantly better than the ones that were only palliative. What about our experience with arterial resections? I want to show you these data that we could just publish in the Annals of Surgery. This was two types of arterial problems. The one was a true resection because of invasion, and the other one was a kind of divestment, which is more or less similar to the triangle operation. You go along the artery sharply, but you don't need to resect the artery. And we compared these patient groups, 195 with a true resection and 190 with a divestment, which has been introduced by Professor Miao from Nanjing. And this is the scheme that we had. Of course, the divested patients all had neoadjuvant therapy. Otherwise, this divestment will not work. You don't get into this tissue along the artery without neoadjuvant treatment. And 50% of the resected patients, arterial resected patients, had neoadjuvant therapy. So the proportion was much less. I think at the moment, we would also do 100% for all of these patients. This is just an example to make this a little more plastic. On the lower part, you see this type of divestment of the artery, this triangle operation, tumor on the left side still in the artery or around the artery. You can split the tumor more or less and can take it away from the artery completely. And on the lower right, you see this tumor, which was around the artery, which can still be seen in the middle of the tumor specimen. And this is a very good operation when you get this layer and when you can do the divestment without resecting the artery. Also, we had the experience of a learning curve. We started the arterial resections with 20 cases per 3 years or 4 years and had a mortality of 20%, quite similar to the Mayo Clinic. We could lower this substantially by increasing our caseloads, which is shown in the lower part of the slide, 71 arterial resections within a 3-year period, 7% mortality, and I think this can even come down more. And for the arterial divestment in the upper part, you have a very low mortality because this is an operation which is not burdened by any arterial complication, bleeding or thrombosis or things like that. So it's really important you do this often, then you can offer this to your patients and you can offer this safely. Outcome was triggered by the usual things that we know, which means T stage, N stage, M stage, of course, are the predictive factors. However, the arterial resection and the arterial divestment did not differ in survival. And of course, the R0 and R1 resection that we know from upfront surgery as a very important factor was not that important after neoadjuvant anymore, which is quite interesting, I think. But this is in line with some other studies that have been published recently, that after neoadjuvant treatment, the R status doesn't have that important impact as in upfront surgery. Now, one interesting thing I just want to mention at the end is what is the impact of adjuvant after neoadjuvant. This was a multi-center analysis from the Dutch colleagues, 520 patients who all had at least 2 cycles of FOLFIRINOX neoadjuvant in all pancreatic cancer stages of resectability. You see why they did adjuvant or not after the resection. Mostly the ones who were R0 were not considered for getting adjuvant afterwards, and the ones with an N0 stage, of course, also did not get an adjuvant therapy afterwards. The ones who were still N+ or who were R1, they were more considered to receive adjuvant therapy in all of the centers that were involved here. What is the outcome of this? This is the overall survival for all of the patients. You see, there is no difference if you give adjuvant or not after you had neoadjuvant and resection. But there is one other interesting aspect, and this is this. When you have N+ patients who have still positive lymph nodes after neoadjuvant treatment, you can double their survival by adding adjuvant chemotherapy after the operation, despite they already had a neoadjuvant treatment before. And I think this is something you can keep in mind, that there is a subgroup of patients who need adjuvant after neoadjuvant. The others may probably not need adjuvant after neoadjuvant. The ones who are R0 and who are N0 as well, they will probably not benefit from additional chemotherapy. And in the respective analysis, multivariable analysis, this was the only significant factor. And positive lymph nodes after pre-treatment are the ones who should probably get adjuvant afterwards as well. Now, to summarize and to conclude on this little unsolved topic at the moment, I just want to quote the NCCN web pages because I think this expresses it very well. This is the guideline for doctors. You see, borderline resectable, clear recommendation, neoadjuvant therapy, then maybe go to surgery. This is for the doctors in the NCCN webpage. Now, this is for the patients in the NCCN webpage. You see, advice for the patients, borderline resectable. Surgery should be used as primary treatment if the doctors agree that they can completely remove the tumor. If you have borderline, you might have neoadjuvant therapy. So I think this explains very well that we are not really sure about what to do at the moment. One thing, of course, yes, of neoadjuvant for every patient borderline, but on the other hand, you have might recommendations and you can also do it differently. So it still remains controversial. From our point of view at the moment, venous borderline resectable, if it's technically possible, we would go for upfront surgery, but we believe that the ongoing studies may provide much better data in the next years. Arterial, we would always do neoadjuvant and then go for an exploration. Of course, you should consider biology and condition of the patient too. That's what I mentioned in the beginning. And I think these are the problems that we have to face at the moment. We have little high evidence data on the neoadjuvant borderline situation. We don't know how to select the patients, which patient should get what therapy, which patient should get FOLFIRINOX, which patient should get radiation upfront. We just don't have the data. And we still have limited data if we should give adjuvant after neoadjuvant, maybe for a specific subgroup, but this has to be clarified much further in the future as well from my point of view. Thank you very much for the attention.
Thank you very much, Professor Thilo. Now we are going to continue. With Professor Duda. Professor Duda is a director of translational research in GI radiation oncology in Mass General Hospital in Harvard Medical School. His area of research is tumor interaction with its microenvironment and impact on resistance to immunotherapy, anti-angiogenesis, and cytotoxic therapy. Professor Duda is founding editor of the Surgery, Gastroenterology, and Oncology, and a senior associate editor of Red Journal. He is currently serving as the Secretary General of IASCO, and his today's topic is how do we make progress in pancreatic cancer therapy? Please, Professor Duda.
Yes, thank you very much, Professor Dane. Again, it's a great pleasure to be with you this evening. As you've heard already from my distinguished colleagues, pancreatic cancer remains a major problem. We still need to make progress for its therapy. And I would argue tonight, that the major way to do this is through understanding better the biology. So I will give you some of the examples how we tackle this problem beyond this developments and technical developments or scheduling developments. But before I do that, I'd like to go over some of the efforts that IASCO is making. You've seen this in Professor Takaori's presentation. IASCO has really been created as a multidisciplinary society. We really welcome all specialties, and we understand that it really takes a team and an inter and multidisciplinary approach to solve problems such as GI malignancies, which remain, as I was saying in the beginning, largely an unmet need. And a lot of the advances in technology, in surgery, you've heard already, I think scheduling treatments, I think really the biology hopefully will bring us further along with this type of therapies. So IASCO, just want to give a few words of introduction. We have a very, very diverse membership. We also have a great leadership, pioneers in the areas of oncology, surgery, transplantation. We have publications, as you've heard, Surgery, Gastroenterology, and Oncology is our current official journal. And we organize courses such as this one, and obviously the annual Congress is our main event. Unfortunately, this year's Congress in Taipei will postpone for next year, and the next one, as you heard, will be in your beautiful city of Istanbul. We also offer opportunities for training for specialists from all over the world, and I think that's what distinguishes us from many other organizations. This is our official journal. It was created 3 years ago. I highly encourage you to read it as well as contribute with your best articles. So in terms of the educational program, we've always had a very rich educational program. Istanbul has featured every year with a wonderful postgraduate course. You see this, the list from last year. Obviously, this year, things have changed dramatically with the current pandemic situation. However, I want to commend Professors Dulundu and Dane for putting together such a great program. We're going to have some other meetings. We had one in Seoul, Korea. We're going to have some others in Europe, and you will see the announcement soon. So this is my disclosure for my talk today. Really, I will not discuss drugs from any of these companies, and there's absolutely no conflict. The other disclosure is I'm actually a scientist. So everything I will say that relates to therapy is actually because I have really the honor to work with really distinguished leaders in the field of pancreatic cancer surgery, Carlos Fernandez, radiation oncology, Ted Hong, medical oncology, Andrew Zhu, Jeff Clark, David Ryan, and so on and so forth. So I'm really fortunate to be part of a team of a really top team, I would say, in the multidisciplinary approaches to pancreatic cancer. So very briefly, obviously pancreatic cancer survival remains dismal. If you look at American database here, this is from 2014, looking at the 5-year survival, obviously you can see that pancreatic cancer is by far the worst outcome, with only less than 10% of the patient making it to 5 years. And obviously the other problem is that the incidence is actually going the wrong way. So you see that the incidence is actually increasing. So obviously these two factors create a major problem that is here to stay. In terms of survival, obviously the metastatic disease will have the worst survival. This has been already discussed extensively, so I don't necessarily want to go over this, but it just suffice it to say that once the disease has advanced, the chances of the patients to really reach to 5 years drop dramatically, while if the tumor is localized and potentially resectable, you see that it's perhaps 35% of them might be able to survive for 5 years. And now this issue of surgery, obviously surgery is the only curative option. There's absolutely no doubt about it, but I think we have a long way to go to really go beyond in terms of long-term survival, such as 5 years. You see here with and without Whipple. These are data from the Herzberg Foundation, showing that even after resection, the survival is actually quite low. So again, surgery remains the mainstay of a curative treatment, but of course, this is a systemic disease. Adjuvant FOLFIRINOX, as you've heard, has made great advances starting from a metastatic setting, moving now into earlier stages. And of course, as you all also heard from the beautiful talk by Professor Hackert, borderline resectable patients may benefit from preoperative chemoradiation, although this remains an area of controversy. And obviously, locally advanced patients treated with neoadjuvant FOLFIRINOX may have a chance to proceed to curable resection, and I think this is quite of an exciting area as well, of potentially making progress here. So I think one of the questions we've been asking for more than a decade now with our colleagues at MGH is, can PDAC, primary disease, can be intercepted early with a clear understanding that obviously when the disease is localized, curability is quite high. As we move along with disease progression, especially when the tumor cannot be resected completely or there's a lymph node involvement, as you've heard already from Professor Hackert, really the potential for cure is getting close to zero. So the idea is, how do we intercept the tumor earlier? And so you see here some numbers. So obviously the curability decreases, as I was saying, with stage. Unfortunately, diagnosing at this stage is actually very rare. Most of the patients are diagnosed with advanced disease. The other problem that has marred this disease has been that the treatment has been inadequate. So we didn't really have the proper tools to really have a cytotoxic therapy that would limit the disease or convert it to resectable. And if you look at, so this is basically the phase 3 trial that established gemcitabine with capecitabine as adjuvant treatment, standard of care. But you see here, 60% of the patients in this trial actually had R1 resection, and 80% of them had node positive disease. So obviously this goes back to the points that Professor Hackert was making. Obviously this will carry, a poor prognosis, and perhaps this is one of the reasons why these curves don't really separate much. So again, cure occurs in a very, very small fraction of patients. We don't really have the biomarkers right now to identify those patients. So again, very briefly go over this because you've heard about it. FOLFIRINOX was established first in the metastatic setting. Patients who tolerated had an significant increase in survival. And then as adjuvant therapy, as you also heard, FOLFIRINOX seems to have an advantage over gemcitabine. And these are probably the best survival data we've ever seen in a phase 3 trial. Interestingly, also for gemcitabine, they're actually quite amazing. But in any case, you see here over 50 months overall survival with modified FOLFIRINOX treatment. So I'd like to discuss some of the challenges. How do we halt cancer progression, prevent treatment resistance? How do we base new therapies on understanding the mechanism of action and targeting this resistance? And how do we integrate potentially curative immunotherapy, which has made a difference in many other cancers, but unfortunately not yet in pancreatic cancer? So this issue of can it be intercepted early? This is work that we've started, I think, about 14 years ago. So the idea here was, as you've heard, chemoradiation obviously takes a long time. It carries the risk of progression because if it's given over many weeks, obviously this is a very aggressive disease, may progress and patients may become unresectable. So one of the approaches we've taken was to give a short course of proton therapy with chemotherapy, and then the patients will undergo resection immediately without any delay. In fact, this approach was feasible. We've been able to complete the study, which showed that there was no problem in terms of resectability. This paper was published, and I think it was a very nice example of how we could combine a multidisciplinary team. You see here, all the specialties were basically involved in this: pathology, radiology, surgery, medical oncology, and biologists, and so on. So this paper is very rich. I highly recommend you read it. We looked at many biomarkers, but the long story short is, while this approach was able to really control local recurrence, we see over 90% local regional control with this short course of chemoradiation. In fact, distant metastasis was not necessarily inhibited at all, and most of the patients progressed and succumbed to the disease, unfortunately, without local progression. So obviously, once again, the issue of distant disease, metastatic progression limited the efficacy. One of the markers we identified in this rather small study was looking at hepatocyte growth factor. This is a very well-known pathway by which cells tend to metastasize. It's also called the scatter factor, binds to the mesenchymal epithelial transition receptor MET. And this trial was associated with overall survival. And I'll come back to that. We also looked at larger databases, looking at the MET receptor in the cancer itself. And indeed, this is a much larger cohort of patients, almost 200 patients. You see a very strong correlation between high levels of this receptor in resected specimens and shorter overall survival. But again, I'll come back to that. Let me first talk about this interception. So one of the first efforts was to bring FOLFIRINOX with chemoradiation for borderline resectable. This paper was published a couple of years ago in JAMA Oncology, and I would say the results are very promising. So in this trial, basically 97% of the patients achieved R0 resection. Again, I think this is a very important endpoint in any trial. And this obviously was higher than the R0 resection rate that they had before. So obviously very promising. Another very interesting area we've been looking at, for the last 20 years, I would say, is really understanding the complex microenvironment of this pancreatic cancer. In fact, pancreatic cancer tends to have a lot more stroma than their cancer cells, which in some cases could be actually less than 10% of the tumor itself, and trying to understand the role of fibrosis, the role of immunosuppression, and some of the factors that drive progression. And again, this is a picture of a cancer. You see very, very rich in stroma, very rich in matrix components such as collagens, hyaluronan, and so on. So, one of the findings in our lab made by my mentor, Professor Dane, in collaboration with my colleague, Dr. Boucher, was that one of the drugs that is routinely used to control hypertension is called losartan, an angiotensin receptor blocker, is actually able to change the matrix composition of tumors by reducing the activation of the stellate cells. So in turn, basically through the TGF-beta pathway, by inhibiting thrombospontin 2, losartan is able to reduce deposition of collagen, HA, and other matrix components, CTGF, and so on. So this was a serendipitous observation that they made. I think this is very important for the mission of IASGO also, because this drug costs 75 cents. So this is not the cost of an antibody that could cost hundreds of thousands. This is really something that we've been using for many decades and could be actually employed anywhere in the world. Anyway, going back to the science of it, if you look at the patients who took angiotensin system inhibitors versus those who didn't, this is a large cohort that was published by my colleagues also a few years ago in clinical cancer research. You see clearly superior survival in patients who actually took angiotensin system inhibitors with comparable treatments. So we have this prospective clinical trial that was testing the addition of losartan to FOLFIRINOX. So basically, this is a single-arm trial. Patients received FOLFIRINOX in neoadjuvant setting. These are locally advanced pancreatic cancer patients. Most of them proceeded to all 8 cycles of FOLFIRINOX. Some of them didn't. Then 45 of the 49 proceeded to short course proton therapy, some of them long course photon therapy. And then in the end, 42 underwent attempted surgery and 34 were resected. So this is the waterfall plot with the responses. You see some of them were really profound responding, including complete response. And obviously there were some that progressed. But I think the most important finding of this paper, which came out in JAMA Oncology last year, is the fact that in this patient population of locally advanced, the R0 resection rate was over 60%. And there was also another patient with R1 resection. So this is really unprecedented rate of R0 resection in this patient population. So we're very excited about this result, because compared to our data at our own hospital, looking at FOLFIRINOX plus radiation therapy, this is clearly a much higher 3-fold increase in R0 resection. We also were able to confirm that losartan treatment reduced the TGF-beta levels, which is what we think is the mechanism of action here, which involves, again, stroma deposition as well as immune suppression effects. So this led to a randomized phase 2 trial that is currently ongoing with support from the Stand Up to Cancer Initiative and American Association of Cancer Research. Is actually involving 10 different institutions where patients undergo neoadjuvant treatment with FOLFIRINOX, and losartan, as well as with FOLFIRINOX and losartan, and then with nivolumab, which is a PD-1 antibody. Again, with a hypothesis that losartan perhaps can modify the immune environment, hence making the tumor responsive to immunotherapy. Then all patients undergo surgery, and there is also an adjuvant setting. Losartan is continued or alone or with a PD-1 antibody. We're very excited about this. 100 patients have been already enrolled. There are very many studies being conducted here. There are serial biopsies, there are surgical specimens collected, there's a lot of imaging, blood samples, and obviously we're all very excited to see the results and also learn a lot from the correlative studies in terms of the biology of the disease. Again, it's a very large team. I don't have time to go over that, but just want to commend all my colleagues who participate in this. And then last few minutes, I want to talk about metastatic disease, because I think whether we like it or not, obviously the occult micrometastases are present in the vast majority of patients at the time of diagnosis. And then the question is, how can we intercept the metastatic disease early? So again, one of the findings we made in that particular study of resectable PDAC with short course proton chemotherapy was the level of HGF correlated with overall survival. And just very briefly, this is a pathway that has been studied for about 30 years. Unfortunately, hasn't been really used for treating cancer, with the exception of very recently approval of a MET inhibitor in the context of lung cancer and EGFR mutant cancer. But overall, I think we're yet to use the potential of blocking this particular pathway, which has to do with survival of cells, polarity, motility, proliferation, most of the critical events that are important for metastasis. So MET can be upregulation can be a genetic event, for example, amplification. It can also be act as a proto-oncogene where there's high expression of the ligand, as I was saying, the hepatocyte growth factor, or high expression of the receptor increase in the metastatic cells. So this is something we're working on very actively. Hopefully we'll be able to report the data soon. But in the meantime, I want to leave you with a few thoughts. I really think that if we want to make progress in this disease, I think beyond this wonderful technological advances and surgical advances, the early interception would be really one area where we could make a leap forward. And I think it's the last frontier in PDAC, and really using mechanism-based biomarkers, I think are needed to help the trial design as well as the treatment. And this is what we're trying to do. Of course, we still have to validate the concept, but that's our direction. With that, I want to thank most of the people who worked on this in my group, as well as our collaborators from all over the world. Also the general support we receive for our studies. And also thank all of you for your attention, and also point out to different online events that we have. We have a really nice course of hepatopancreatic biliary cancer symposium, which usually was held in Arizona. This is with the Mayo Clinic. Will be held online November 13, 14, same dates. There will be a very nice webinar that will take place in Cairo, where we also used to have for many years postgraduate course. So with that, thank you for your attention, and happy to participate in the discussion.
Thank you very much, Professor Duda, for the excellent speech and for very fruitful talk. And now we are going to move to the next and the last speaker, who is Dr. Sedat Tarık Fırat. He's a medical oncology fellow in Erciyes University.
Excuse me.
Turkey.
Excuse me,
Sorry.
Professor Dane. Professor Takaori, now he solved the problem, I think, regarding to his internet. And just I would like to ask to him if he would like to say something to us, because very big time differences between Turkey and Japan. Now maybe it's around the 3 o'clock at night, isn't it, Professor Takaori?
Oh yes.
Thank you very much.
Thank you. Yeah, thank you, Professor Durand. I'm sorry to interrupt, but I had some problem with the internet connection, and now I'm connecting through my mobile phone. So I'm not sure if the connection here is good enough, but I'm glad to meet all of you. And if it is possible, I can give a very short talk. So we are the scientific society that promotes multidisciplinary approaches to the treatment. And pancreatic cancer is a highly lethal disease for which mortality causes incidence. Most patients with pancreatic cancer remain asymptomatic until the disease reaches the advanced stage. And I really enjoyed the talk of Professor Duda about our interception. And pancreatic cancer, 40% are metastatic disease, while the remaining 60% are local disease, which can be classified into locally advanced, borderline resectable, and resectable cancer. And in the past, we used to offer upfront surgery for those patients with resectable pancreatic cancer. However, the situation is changing. Professor Uno has presented a paper about PrEP02 JSAP05 phase 2-3 study in ASCO GI last year, and they compared upfront surgery and neoadjuvant chemotherapy with gemcitabine. And they concluded the overall survival was better and longer after neoadjuvant chemotherapy with gemcitabine plus this1 as compared to upfront surgery. So our strategy has already changed. In Japan, all patients with local disease undergoes neoadjuvant therapy. And only those patients, priority patients, receive upfront surgery. And about 10% of patients are borderline resectable. For those patients, we offer IMRT or intensity modulated radiotherapy with full dose gemcitabine at Kyoto University. Because IMRT can provide with very good local control. So this is actually the clinical target volume of IMRT. So we irradiate the tumor and lymph nodes and vessels around the tumor. And we compared our retrospective cohort of neoadjuvant chemoradiation and neoadjuvant chemotherapy for borderline resectable pancreatic cancer with arterial involvement. And as a result, overall survival was not significantly different between neoadjuvant chemoradiation and neoadjuvant chemotherapy, although there was a slight increase in the overall survival after neoadjuvant chemoradiation. And the disease-free survival was slightly longer in the neoadjuvant chemoradiation team, although there was no statistical difference between the two arms. But very interestingly, the patterns of recurrence after neoadjuvant chemotherapy and neoadjuvant chemoradiation was quite different. There was a very low local relapse after neoadjuvant chemoradiation. But we have to manage other metastatic patterns. And another challenge for surgeon is that we had a lot of fibrosis after neoadjuvant chemoradiation, and this makes operation very difficult because the dissection around the vessel was quite difficult after effective neoadjuvant chemoradiation therapy. And also, about 20% of patients are complicated by locally advanced pancreatic cancer. For example, if the tumor is located like here, the surgeon has to remove the celiac artery and common hepatic artery by means of a DP curve or distal pancreatectomy with celiac artery resection. So again, by introduction of neoadjuvant treatment, a lot of patients with advanced disease, such as locally advanced borderline resectable pancreatic cancer, come to operation room. And this is a technical challenge for surgeons. Then what can we do about this difficult situation? One of the solutions is the artery-first approaches to pancreatic resections. It was Professor Akimasa Nakao who proposed isolated pancreatectomy for pancreatic head carcinoma. And the group of Heidelberg, Dr. Weitz, Labari, Koch, and Bucher have proposed the artery-first approach for resection of pancreatic head cancer. According to the literature, artery-first PD is associated with less blood loss and higher R0 rate. And early determination of resectability is possible by means of artery-first PD because we approach SMA margin first. And it is believed artery-first PD is more oncologic by blood flow isolation. And it is also assumed this may prevent dissemination and liver metastasis. Then what is artery-first approaches by definition? The artery-first approach for pancreatic resection is based on the concept to isolate pancreatic blood flow before extensive mobilization of the pancreas. The inflow, such as IPDA and gastroduodenal artery for PD, splenic artery for DP, cerebral artery for DP car should be ligated or divided before the transection of the pancreas. My good friend, Dr. Strasberg, has proposed radical anticoagulated modular pancreatic splenectomy, or LAMPS. This is indeed a very good operation for advanced pancreatic cancer. But the only drawback is that the surgeon has to transect the pancreas before the ligation of splenic artery. So for example, if the tumor is located in the pancreatic body, it is not possible to approach the origin of splenic artery. Like this one. You cannot touch the splenic artery without compromising the surgical margin. Then how can we do artery-first DP? So we learned lessons from laparoscopic distal pancreatectomy. Here, the surgeon is lifting the pancreas body and approaching the splenic artery from the posterior surface of the pancreatic body. Yeah, I'm sorry that the video is not moving correctly, but I think you can understand what I mean. And artery-first approaches to distal pancreatectomy can be done in the robotic setting also. So here I am dissecting above the left renal artery and vein and mobilizing pancreatic body, as well as the zerotas fascia beneath the pancreatic body, so that we can ensure the negative surgical margins. And we can also see the splenic artery from the posterior surface of the pancreatic body. Here you can see the celiac artery and splenic artery. In this way, we can convert the DP to DP curve if needed, because we expose the celiac artery first and then splenic artery. Of course, artery-first approaches to DP can be done in the open setting also. The key is the cold-cranial direction view, like this one. So I always lift up the transverse colon and approach the pancreas. So this is the name. One may not catch a tiger's cub without entering a tiger's den. This is actually the proverb from textbook Han Dynasty. And we call our approach tiger's den approach, like this one. So here I am drawing the margin of pancreas from the other side of the mesentery to explain what I'm doing to my young colleagues. So first, I cut the ligament of Treis and mobilize the upper jejunum, and then I cut the mesentery along the posterior border of the pancreatic body. Then I dissect behind the pancreas, and then again, I cut the mesentery of the transverse colon so that we can resect the mesentery over the pancreatic body and block. Here you can see the pancreatic body and superior mesenteric vein and the superior mesenteric artery. You can also see the left renal vein under the superior mesenteric artery. And then you can insert the carry forceps under the pancreatic body and pass the carry forceps below the pancreas toward the left side of the left gastric artery. And you can use a Penrose drain to lift the pancreatic body. We call this hanging maneuver. So here I'm lifting the pancreatic body. By this maneuver, you can expose the origin of splenic artery and divide it. Here I am clamping the splenic artery, and I'm going to cut it with a knife and then treat the stump with a continuous suture of 6-0-fluorine rather than simple ligation, because I want to avoid aneurysm of the stump. An artery-first approach to DP curve or modified APRO-V is another good operation. I'm afraid the video is not moving correctly again, but here I'm trying to catch the SMA through the tiger's den approach. Maybe you can move forward the video or slide. And then I am dissecting around celiac artery. So by this approach, you can take all the major vessels without dividing the pancreas. So in summary, artery-first approaches to distal pancreatectomy are feasible in all settings of open laparoscopic and robotic surgery. Tiger's den technique is useful in artery-first approach to DP and DP curve. Artery-first approaches to DP and DP-CAR are useful in the setting of pancreatic cancer, especially locally advanced tumors involving the splenic celiac hepatic arteries and posterior tissue after neoadjuvant therapy in the era of multidisciplinary approach. Now I'd like to invite all of you to the 32nd World Congress of International Association of Surgeons, Gastroenterologists, and Oncologists, which will take place from November 20th, 2021 at the Grand Hotel Taipei, Taiwan. And in 2 years, we are planning to organize the 33rd IS World Congress in Istanbul under the leadership of Professor Dulundu and Professor Faysal Dane. And please join us. And thank you very much for your kind attention, despite the technical difficulty. Thank you very much.
Thank you very much, Professor Kyoichi, for your excellent talk. Now we are moving to the last speaker. He's from RGS University, Dr. Sedat Tarık Fırat. He's a medical oncologist fellow, and he will present one of his case related to pancreatic cancer. Please, Sedat.
Okay. Good evening, everyone. I will present you a case of metastatic pancreatic cancer. Patient LD, 50 years, female. She is living in Kayseri, Turkey. She is a housewife. She has 2 children. Symptom, abdominal pain. The complaint of abdominal pain started 4 months ago. Abdominal pain increased after meals and spread to her back. Thereupon, an upper abdominal MRI was performed for the patient in another center. In MRI, 3 metastatic lesions were seen in the liver. The largest was 25 millimeter in size in segment 2 of the liver. A mass lesion with a diameter of 5 centimeters was detected in the head of the pancreas. A needle biopsy was performed on the mass in the head of the pancreas. Biopsy results, malignant tumor tissue completely consists of malignant cells in anaplastic morphology. Morphological findings were reported consistent with pancreatic pleomorphic carcinoma. In the PET-CT of the patient, multiple hypodense nodular lesions, metastases in segments 2, 4, and 6 with moderate hypermetabolic activity in the liver, the largest of which is 24 millimeter in segment 2. A mass lesion, primary malignant process with a size of approximately 56 millimeter and containing necrotic areas in places showing intense hypermetabolic activity in the head of the pancreas. Multiple lymph nodes, metastases, 21 millimeter in size, showing intense hypermetabolic activity within the mesenteric fatty tissue adjacent to the anterior of the pancreas head were detected. The patient applied to the medical oncology outpatient clinic for a treatment plan with these findings. Past medical history: the patient had hypertension. The drug used by the patient is valsartan plus hydrochlorothiazide. She has been smoking once or twice a day for 2 years. The patient had no operation history. Family history: there was no significant feature in the family of the patient. Physical examination: ECOG performance score was 1. There was tenderness in the epigastric region and a palpable mass of approximately 4 or 5 centimeters. In this slide, we see laboratory values. CBC values were normal. Among the biochemistry values, only aspartate aminotransferase and lactate dehydrogenase were moderately high, others were normal. Carcinoembryonic antigen 1.74, CA 19.9, 36. CT at presentation April 2016. In this slide, we see the initial CT image. We see the 6 centimeter lesion in the pancreatic head and largest metastatic lesions in the liver. The mass in the pancreas surrounded the superior mesenteric vein more than 180 degrees. We see the largest metastatic lesion in the liver?
So please, Sedat, would you stop here? Let me ask two questions to our surgeons. Professor Thilo, are you online? I don't know. Or
yes, I am.
Elena. Okay, let's assume that this patient has no liver metastasis and no lymphadenopathies also. So there is only limited vessel involvement, let's say. Would you go for upfront surgery or neoadjuvant therapy in Germany?
Probably this would differ from center to center. But I think if you have a good vein, I did not see the entire CT scan, of course. As I mentioned before, and the artery was not involved, I would probably do an operation first without the metastasis, of course.
So if the patient has 6 centimeter primary tumor, there is no vessel involvement, let's say, but she has severe pain, weight loss, and CA99 is over, let's say, 1,000. Would you do any other radiologic or any other laboratory tests for staging, or would you go for, again, upfront surgery?
No, if you had this situation, I think I would also do the PET-CT. And I mean, the PET-CT could help you for decision-making, because this is absolutely a borderline case also from the biology then, and from the condition of the patient probably. And then probably you would test the neoadjuvant chemotherapy if she can have this and she does not become worse. Maybe afterwards you would decide on surgery or not.
So how many cycles of chemotherapy or the duration of the neoadjuvant therapy in Germany? What is the duration?
We would usually go for 6 cycles of FOLFIRINOX, for example, and after 6 cycles we would do the re-evaluation and then decide.
Okay. Professor Elena, anything you want to add to the comments of Professor Thilo?
No, not so far. I apologize, I did not hear everything. If you have any questions for me, I would be happy to answer.
So let's say the tumor is resectable, but it has, the patient has severe pain, I said, weight loss, and the CA99 is over 1,000, let's say. Would you go for upfront surgery or go for neoadjuvant therapy in Russia?
In case of locally advanced cancer?
Yes, locally advanced, but there is the mass is about 6 centimeters, and there is no vessel involvement.
No what?
No artery or vein involvement.
Okay, then first we need to define if this lesion is exactly adenocarcinoma. I mean, there are many ways, non-invasive ways, especially some MRI versions that could be helpful in defining the lesion, because it is extremely rare situation. It might be almost impossible when you have the classic adenocarcinoma growing to the size of 6 centimeters, not involving any vessels. So you might also consider another options like neuroendocrine tumor and so on. Of course, if you do not have any vessel involvement, you should proceed for surgery. In any case, in the case of adenocarcinoma, in the case of neuroendocrine tumor, or in case of IPMN, the only benefit for us, if this is not adenocarcinoma, but for instance, IPMN, if we have some tumor recurrence afterwards, I mean, local regional recurrence or even liver metastasis, we can proceed for chemoembolization. Of course, if this is primary resectable tumor, of course, you need to proceed for surgery first.
Okay. Professor Thilo, would you do staging laparoscopy for any patient?
We would do staging laparoscopy only for very high CA19-9 and body or tail tumors, not for tumors in the head.
Okay, thank you. And Sedat, you may go on.
Okay. Treatment. We gave 2 cycles of nab-paclitaxel plus gemcitabine chemotherapy. In the abdominal CT performed after 2 cycles. Reduction in the size of the hypodense nodular lesions observed in the liver was noted compared to previous examination. It was 18 millimeter in the new examination. A mass lesion with a diameter of 6 centimeter observed at the level of the pancreatic head continues similarly. The mass content was observed to be more hypodense in the new examination, maybe necrosis. Metastatic lymphadenopathies observed on the medial side of the mass persisted similarly. The CA19-9 value decreased to 12.9. After 2 cycle treatment response, in this slide, we see the shrinkage in the largest metastasis in the liver. We gave 2 more cycles of nab-paclitaxel plus gemcitabine chemotherapy. In abdominal CT, there is a regression in the size of the nodular lesion, which is 18 millimeter at the level of liver segment 4 and 2, and it was measured 15 millimeter in the last examination. There was no significant difference in the size of the lesion, which was 6 centimeter at the level of the pancreatic head. However, in the last examination, its internal structure is observed as more hypodense, necrosis maybe. CA19-9 was 10.9 detected. We gave 2 more cycles of nab-paclitaxel plus gemcitabine chemotherapy. The lesions in the liver were stable in the radiological evaluation performed after a total of 6 cycles. Metastatic lesions in the liver turned into cystic form. The lesion on the head of the pancreas decreased from 60 millimeter to 53 millimeter. Solid areas inside have disappeared. After 6 cycle, in this slide, after 6 cycle, we see that the solid areas in the lesion in the head of the pancreas disappeared and metastasis in the liver regressed. The mass in the head of the pancreas wasn't suitable for surgery because of its close relationship with vascular structures. The patient was followed up without medication. The lesion on the pancreatic head regressed to 43 millimeter in the radiological evaluation 4 months later. The patient was followed up without chemotherapy. The lesion on the pancreatic head regressed to 35 millimeter in the radiological evaluation at the 7th month after treatment. In the last examination, there was a moderate reduction in the size of the hypodense nodular lesion on the border of liver segment 2 and 4. Average 30 millimeter in the previous review. In the new review, average 11 millimeter. Radiological evaluation was stable at the 10 months after treatment. The lesion of 35 millimeter in the head of the pancreas regressed and measured average 23 millimeter in the 21st month evaluation. PET-CT performed in the 36th month. Lesions of 21 millimeter in the head of the pancreas and 18 millimeter in the liver segment 4 didn't show metabolic activity. The patient has been followed for approximately 4 to 8 months without any progression and recurrence. This is my last slide. We see our last assessment in August 2020 comparatively with the first one. The mass in the head of the pancreas regressed to approximately 2.5 centimeter. 2 of the lesions in the liver disappeared, and the lesion in segment 4 regressed to approximately 1.5 centimeter. No activity was detected in this lesion in PET-CT. Thank you.
Thank you very much, Sedat. Professor Thilo, would you offer any kind of treatment to this patient now?
Well, that's a very difficult question because this is an extremely interesting, uncommon case. This was an anaplastic cancer, I understood.
Yes.
Yes.
Yeah, I mean,
Anaplastic pleomorphic carcinoma.
Pleomorphic carcinoma. This is extremely unexpected. So I think at the moment, I would just observe this patient after 4 years, stable or remission without any therapy in the last 3 years, or I understood right. There was no therapy and it was just stable. So I think I would not do anything at the moment because this is something that we don't know. This is a case very special.
Okay. And we know there are some retrospective studies evaluating the effect of metastasectomy in pancreatic cancer. Do you have any patients, do you offer any patients metastasectomy in pancreatic cancer? I'm asking Professor Elena and Professor Thilo.
Thank you for your questions. It's quite interesting question. If a few years ago, we would not recommend for the patient having metastasis any surgery. So nowadays we have we have the review from Marco Del Chiaro from the United States, confirming that if your patient has single metastasis, single, for instance, liver metastasis, it could be removed with good prognosis. The only thing is these patients should be meticulously selected. And of course, if you have pathology confirmation and you have the young patient who can overcome all the aggressive chemo or even radiation they get, it does make sense. And if I'm correct, about 400 patients known as for now I mean, this review is highlighting about 400 patients who did benefit, as some of them did benefit from single metastasectomy along with pancreatic duodenectomy.
Professor Thilo, anything you want to add?
No, I would agree with Elena that you should select these patients very carefully. We do resect metastasis. We have also published a series on 85 liver metastasis resection for pancreatic cancer. But of course, you have to pre-treat them very effectively. They have to be stable, and you should not resect more than 5 metastases. And best is if you can do this with minor liver resection and not a formal hepatectomy or something.
And if the primary tumor is also resectable, of course, right?
Yes, of course, sure.
Okay. Professor Kyoichi, anything you want to add?
Yeah. Yes, thank you. And I would like to congratulate on the very successful treatment for this patient. We do operate anaplastic cancer, and usually the result is miserable. And actually, my question for Professor Hackert is that how long do you wait until you do a metastatectomy or resection for extensive local invasion? Do you have any criteria or any particular time span to wait?
Well, usually if you have a metastasis after primary tumor resection, there should be at least 1 year until the diagnosis of metastasis. Then you should do the pre-treatment and then do the resection if this is suitable. If you have a synchronous metastasis, you do the pre-treatment. And in these cases, I think I would want more than 6 cycles. I think you should wait longer than 3 months because this is very short. And if you then still have a stable patient, resectable, primary resectable metastasis, and everything is suitable, then we would do this.
Yeah, thank you for the excellent answers. And because this is a very hot topic in the field of the so-called salvage surgery, and a lot of people think 6 months is a minimum, but I'm not sure it is right or not. If we should wait 6 months, because we have more and more advanced chemotherapy or nivolumab, as Professor Duda have already presented. So probably we will have to discuss further about this issue in the future meetings. Thank you.
Thank you. And there are some questions from the participants. Professor Thilo has shown in his presentation that FOLFIRINOX combination seems to be over nab-paclitaxel or GEM-CAP combination regarding the overall survival. So they asked, what is their current practice in Germany?
Well, the current practice in Germany is differing. In Heidelberg, it's FOLFIRINOX as the first choice. If the patient tolerates FOLFIRINOX, always FOLFIRINOX. I think other centers might do different. There is one randomized trial that is just finished with recruitment. This is the NeoNAX trial, and they have chosen nab-paclitaxel and gemcitabine, but we have no results at the moment. And from my point of view, this is not as good as FOLFIRINOX just because of the results in the adjuvant setting. I mean, the APAC trial was quite disappointing, and the ASCO abstract with gemcitabine paclitaxel, it was not superior to gemcitabine.
So there was a question for me also, why did this patient received paclitaxel in spite of FOLFIRINOX? Because this patient was, I think she was randomized to the phase 2 study related to gemcitabine versus gemcitabine plus nab-paclitaxel, but Sedat may correct me if I am wrong.
Yes, this chemotherapy protocol was given for these patients in a quality of life study, gemcitabine or gemcitabine plus nab-paclitaxel.
Okay, thank you. So as far as I see, there are no any other question. Oh, there is a question here. Is splenectomy needed for any patient? They ask. Professor Kyoichi?
Did you say splenectomy?
Yes. Is splenectomy necessary for any patient? They ask. There is a question here from the participants.
Oh, I see. So it is about my talk. So splenectomy is necessary for distal. Probably I would say 99.9% of surgeons do splenectomy along with the distal pancreatectomy for pancreatic cancer. The probably only exception I would not do splenectomy is that the pancreatic cancer after distal gastrectomy, because with splenectomy we have to do the total gastrectomy because of the blood flow. So, but otherwise, we will always do splenectomy.
Thank you. Professor Duda, as far as I see, you have a comment on the topic.
I mean, this is such an exciting case. I think this is the perfect type of case where you want to learn something. So I've never heard of a response for 4 years without maybe an immune-mediated mechanism. So I'm thinking, that could be, for example, microsatellite instability driven by some sort of immunogenic cell death post-chemotherapy. I mean, there are many hypotheses out there, but honestly, I don't think there's much evidence for a lot of them. And this is perfect case where you can actually look at that. Is there really an immune response, or is there really expansion of a T cell population that is specific to any antigen in that case? And of course, microsatellite instability has been already proven as one of the biomarkers. And also I noticed that the patient received valsartan. So, I mean, looking at fibrosis perhaps might be a very interesting point. So I don't know if there's any tissue from this patient, if there was a biopsy initially, or something like this could be studied maybe based on imaging or some other modalities. But I would say this is the type of case, unusual, let's say, response where you can learn perhaps, you know, some of the mechanisms by which this can happen. That's all.
Thank you. And I don't know if there is next generation sequencing for this patient or not, Sedat.
No, we don't have next generation gen sequencing for this patient.
But you can have, for example, if you have blood, one can maybe get circulating DNA or you know, at the time, if it was collected, maybe circulating tumor cells. So I think there are ways these days where some of this can be interrogated.
Thank you. And there anything you want to add?
For this patient, I would like to, not for this case, but I would like to ask the question to Professor Takaori and Professor Hackert. Professor Hackert, you show very excellent and impressive operations. I would like to know, when you dissect around the superior mesenteric artery or when you resect, is there any difference regarding to complication about the diarrhea or Shilo's fistula, or how can you manage those complications in these patients?
I didn't understand everything, but I think it was about the artery resections and the morbidity.
Yes, morbidity, especially for the extensive dissection, because diarrhea or Shilo's fistula or such kind of complication. Yes. Professor Takaori and Professor Hackert.
Yes, you have both of these complications. You have lymphorrhea and you have diarrhea in approximately, I would say, 20% of the patients, where you also can have a lymph leak, which you have to treat afterwards. But usually you can handle this today, and the diarrhea as well. So this is the price, of course, you pay for a radical resection.
Yeah. Yes, I think this is a very important question. And as you know, Japanese surgeons used to remove all the nerve plexus around the SMA and everything around the aorta. But we don't do it any longer because I think it's very important to give the effective adjuvant chemotherapy after surgery. And probably the adjuvant chemotherapy is probably most significant factor to determine the prognosis. Therefore, we do not remove nerve plexus around the SMA. And to ensure the negative surgical margin, we use the IMRT, or neoadjuvant chemoradiation therapy, to so that we can preserve nerve plexus. Only when the tumor is invading SMA or other part directly, we remove that part only, but we still preserve the nerve plexus. So that is our policy now. Thank you.
Thank you very much. Thank you.
I would like to add some a small comment. Actually, maybe it would be useful, especially for young surgeons, when I have such a cases, such an unusual cases, rare cases. I'm trying to get a second opinion, third opinion, fourth opinion from independent pathologists from different institutions. And for some cases, after the meticulous review, we got some another and some actually occasionally outstanding outcomes. For instance, I'm remembering well the patient who who underwent laparotomy, and upon opening the abdomen, we found the locally advanced tumor with small lesions like small multiple metastases on the liver surface. And a few months later, the lesions disappeared completely because we need to reoperate this patient for another pathology. I do not remember, that was either appendectomy or something like that. And we did found upon real laparotomy that there were no liver lesions, completely intact pancreas surface and so on. And a few months before, we saw locally advanced and metastatic disease, like classic one. So upon the pathology review, no one among pathologists, but the first one did find the cancerous cells. So it is important to, it is not, actually no one could predict and could avoid the just human fault. So a pathologist is an operator, he's operating microscopy, he's operating so pathology at all, and he also can make some mistakes. So this is important to get the opinion from another pathologist, I think, in those cases. Thank you.
Okay, thank you. There is one more question from Professor Ömer Günal. He just wonders if staging laparoscopy is standard in USA, Japan, or Russia. Professor Kyoichi?
Yes.
Do you do
yes.
Staging laparoscopy?
We do staging laparoscopy for the cases which undergoes clinical trials. Just make sure that correct staging. But in daily practice, we rarely use laparoscopic staging, except those with a suspected peritoneal dissemination on CAT scan.
Professor Elena, anything you want to add in Russia?
Thank you. Primarily, I would say we have very good radiologists in order to allow us to know in advance, I mean, before we proceed to surgery, if patient has some metastatic disease or local advanced disease. And in extremely rare cases, when we are unsure whether this is metastasis, but it is, again, this is extremely rare when we use staging laparoscopy. Usually we use multiple modalities like endoscopic ultrasound, MRI with ADC mapping, CT scan, and so on.
Okay, thank you very much. As far as I see, there is no any other question here. Anything you want to add from the speakers, or Ender, you may add also.
Hocam, bir sorumuz geldi.
There is a question, I think.
Okay, go on, Ender.
Actually, I can see the question. If you want, I can read it. So this is about the story I showed about plasma ASGF, where the question is whether it's used in clinical practice. And unfortunately, you know, because most of the data are from single arm studies or usually small studies, I think this is one of the areas where we're lacking validation. So we try as much as possible to integrate biomarkers prospectively in clinical trials. We actually have plasma ASGF prospectively validated in a phase 3 trial now in liver cancer. And I really hope we can do the same in cholangiocarcinoma and pancreatic cancer, because I really think that could give us really important information beyond just CA19-9 and some of the other very useful biomarkers otherwise. But yes, I think this would be great. It's very easy to standardize. I think the knowledge has been around for decades, as I said, but I don't think we took advantage of it as much as we should have. And that's one aspect of the biomarker point. The other aspect is treatment. So I think, again, we have a paper that was submitted, hopefully it will come out soon, where we show how we can actually take advantage of this for treatment, in particular of early metastatic disease.
Thank you, Professor Duda. So there is no any other question, and we have shortage of time, you know. If there is no any other comment from our speakers, we may bye-bye to all of you. Thanks very much for joining us.
Thank you very much.
Thank you very much
as well.
Thank you very much. You are very busy, and especially Professor Takaori, very late at night from Japan. Thank you. Thank you for.
I'm sorry about the technical problem.
Thank you all the speakers and attendees, and I was happy to see everyone.
Thank you.
Yeah.
Thank you very much.
Yeah, thank you for organizing. This is great.
Thank you. Thank you for your supporting us. Thanks.